My name is Paula Rodriguez Otero. I am a hematologist working at the University of Navarra in Pamplona, Spain. Definitely, this is a hot debate, so whether to treat or not to treat high-risk smoldering multiple myeloma. So in favor of treatment of early intervention in high-risk smoldering, we do have now several phase 3 randomized studies showing a consistent benefit in terms of delaying progression to active disease. And we have also 2 studies. One, a first trial led by the Spanish myeloma group, evaluating lenalidomide against observation that show also benefit in overall survival. And we also have a more recent study comparing daratumumab versus observation. And that study also showed benefit in overall survival when we treat early in the phase of high-risk smoldering multiple myeloma. So I would say that there is increasing evidence that is in favor of treating these patients early in that phase before they develop a slim crack criteria. Cons or limitations, I would say, of treating high-risk smoldering is that we do not have very sophisticated diagnosis criteria. So the definition of high risk relies on the amount of M component, the amount of free light chains, and the percentage of clonal plasma cell in the bone marrow. So it's not that sophisticated, and discriminatory capacity is still limited, and we can only predict a 50% risk of progression in 2 years, meaning that the prediction capacity is limited. So, and that is one of the biggest limitations when we think about treating or not treating. So now there is a lot of physicians that they prefer not to treat, and instead of intervening early, they monitor closely the patients and do a functional imaging to detect the slim crack as early as possible and treat those patients either with a clear evolving pattern or that they are already moving into active disease early instead of in the smoldering phase. My guess is that in the future we will incorporate better diagnostic tools and more sophisticated technologies that may allow us to better identify among the high-risk smoldering those who truly are going to progress to active disease. So normally it's someone runs electrophoresis, a protein electrophoresis, either in the context of other symptoms, other diseases. Per definition, smoldering myeloma is asymptomatic, but eventually, I don't know, just in a checkup or I don't know, because of other reasons, and we do see the monoclonal component, and then that triggers other exams. And when we do see more than 10% infiltration in the bone marrow of clonal plasma cells, or more than 3 grams of M component, there is the diagnosis of myeloma, and in the absence of a slim crack, we make the diagnosis of smoldering disease. So normally it's completely asymptomatic. The LINKER-SMM1 study is a phase 2 study that is evaluating Linvoseltamab, which is a BCMA by CD3 bispecific antibody in the context of a high-risk smoldering multiple myeloma. So this study is conducted by the Spanish myeloma group. So Linvoseltamab is a bispecific antibody targeting BCMA that is approved for triple-class exposed relapsed refractory multiple myeloma in Europe and also in the USA. And the approval was based on the phase 2 pivotal LINKER-SMM1 study showing high overall response rate and a median PFS that was not reached, with a follow-up that was close to 2 years. So why early intervention in high-risk smoldering? Because we do believe that in this early setting where the disease is probably more sensitive and also the immune system is more functional, we could significantly delay or prevent progression to active disease. So the study design is a phase 2, a single-arm open-label study that is enrolling 40 patients with high-risk smoldering myeloma, defined as a diagnosis of a smoldering disease within 5 years of study entry, and the presence of high-risk features either using the Mayo 2018 2020 criteria or the PITHEMA criteria. So this study had two portions. So the part one was a safety running phase that enrolled 6 patients with a primary endpoint of safety. And the part two, which is the expansion phase, enrolled 34 patients, and the primary endpoint is efficacy, a measure with a complete response rate and MRD negativity at 1 and 2 years. So patients would receive Linvoseltamab, 200 milligrams every month, with 3 step-up doses that are given every week. So on week 1, 1 milligrams, 4 milligrams in week 2, and 25 milligrams on week 3. And the treatment is continued for 2 years, and then it is stopped, and the patient entered a follow-up period. So far, we will present data of 24 patients that are enrolled and have received a treatment. So the median age is 63 years. All patients were high-risk smoldering. 18 patients were defined high risk by Mayo criteria, 6 patients by PITHEMA, and 11 out of 24 patients met both Mayo and PITHEMA criteria. So regarding the safety results, we do see a better, more favorable, I would say, safety profile of Linvoseltamab in this high-risk smoldering population as compared to the relapsed refractory disease. We do see a lower rate of grade 3 or higher treatment-related adverse events. So only 38% of the patients develop a grade 3 or 4 events. No patient discontinue due to adverse events, and no deaths so far in this study. So CRS was seen in 42% of the patients, but all the events were grade 1 except a single grade 2 event that fully resolved. No ICANS event were observed, and also we do see a much lower incidence of grade 3 or higher infections. So only 3 patients developed 3 grade 3 events. So 1 COVID infection, 1 Salmonella gastroenteritis, and 1 Staphylococcus epidermidis bacteremia. So regarding efficacy, we have 18 out of these 24 patients that are evaluable for response. So among the 18 patients evaluable, overall response rate was 100%, with 74% of the patients achieving at least a very good partial response or better. So the follow-up of the overall cohort is still limited, with a median of 4 months. So if we take a closer look to the 6 patients treated in the safety running phase with a longer follow-up, we do see that 83% of the patients achieve complete response or better. So we do see consistent deepening of the responses, and among 12 patients with evaluable samples for MRD, all 12 patients were MRD negative at 10 to the minus 6. So overall, we do see a manageable safety profile, more favorable as compared to the safety profile of Linvoseltamab in the relapsed setting, and high activity with 100% responses that deepen over time, and also a high rate of VGPR or better. So we believe this data from this ongoing study, although still preliminary, supports the evaluation of this drug in the setting of high-risk smoldering. So in general, patients with high-risk smoldering myeloma, 50% will progress to active disease in the following 2 years. So with what we are doing now is really delaying that progression, or even preventing completely that smoldering patients to ever developing any criteria. So this is the whole rationale behind early intervention in myeloma. What is important of the study is that we see all patients achieving response. For example, if we compare this data, very preliminary, limited number of patients as of yet, with the phase 3 randomized study that we just discussed at the beginning, LEN versus observation of daratumumab versus observation, the overall response rate is much lower. It's not 100%, and we do not see that depth of response or complete eradication with MRD negativity in very deep levels. So really what we believe, and this is the hypothesis of using these potent drugs in this setting, is that because we are going to clear completely the disease, eventually never ever these patients will develop myeloma and will be potentially cured in a moment where the disease eventually is less resistant, with less clonal diversity, with less genomic instability, and in a patient that is in better condition and with a fitter, let's say, immune system.